Good evening, dear doctors. My name is Dr. Harshveer Singh Mali. I'm the lead for medical affairs for oncology at Merck India. And on behalf of Merck, I welcome you all for today's educational webinar on management of advanced urothelial carcinoma. For today's meeting, we have quite an insightful series of lectures and a panel discussion which will be moderated by Dr. Amit Rauthan. As we move into the meeting today, just wanted to cover a couple of points on metastatic urothelial carcinoma. Metastatic urothelial carcinoma is a very aggressive disease. While the initial responses to chemotherapy may be high, the median survival is somewhere around 15 months. And with a 5-year survival rate, which is very modest at 15%. It is also characterized by genomic instability, high PDL1 expression, DNA damage response mutation, and high TMB. And that is why there are multiple advances which are going on in the treatment of bladder cancer. The objectives for today's meeting will be looking at how we can extend the survival of patients who are presenting with advanced bladder cancer. What are the advances in the treatment strategies that can help the patients? How we can optimize these treatment managements and the factors that can be chosen to consider the right treatment for right patients. For this insightful discussions, we have panelists and faculty joining us from southern part and the western part of India, led by Dr. Amit Rauthan, who will be moderating the session, Dr. Kshitiz Domaria, Dr. Nidhi Tandon, and Dr. Tushar Patil. Our first lecture will be taken by Dr. Nidhi. Dr. Nidhi is the consultant in medical oncology at Narayana Health in Bangalore. Ma'am has also memberships of ASCO, ESMO, and the Indian Society of Medical and Pediatric Oncology. She has authored various original articles, review articles, editorials, and book chapters. And she has a keen interest in the management of hematological oncologies, breast cancers, ovarian cancer, lung cancer, and genitourinary cancers. Ma'am, with that, it's my great opportunity to invite you for the first lecture. Over to you, please.
Thank you very much for the invitation. My topic for today is management of advanced urothelial cancer, second line and beyond. We all know that managing urothelial cancers was a challenge, especially before evolumab maintenance, and there were a very few patients who could reach to second line and beyond. But now once we have the option of immunotherapy maintenance, then we have much more options of second line treatment and beyond, and this is what we will be discussing in today's slides. Next slide, please. So just what I was saying, out of the patients newly diagnosed with advanced urothelial cancers, only 30 to 70% of the patient receive first-line therapy. And this is largely because a lot of these patients are elderly and have comorbidities and are not fit to receive treatment. What is even more unfortunate is that only 15 to 30% of these patients receive second line treatment. This means that even in patients who are fit to receive first line treatment, only 30 to 40% of these patients are able to proceed to second line and beyond. Next slide, please. So in my talk, I would be discussing how to define patient groups, how to individualize treatments for them, along with NCCN guideline recommendations. Next slide, please. So overall, we have three categories of patients who receive first-line treatment for advanced urothelial cancers. Those who are cisplatin eligible and are able to tolerate gemcitabine and cisplatin combination. those who are not cisplatin eligible but are able to take carboplatin, and we offer them gemcitabine and carboplatin. And the third set of patients are the platinum ineligible patient who receive PD-1 and PDL1 inhibitors. We have data to suggest that those patients who have received chemotherapy in form of gemcitabine and cisplatin or gemcitabine and carboplatin and have achieved at least a stable disease, they have an increase in overall survival and progression-free survival with avelumab maintenance. And all these patient groups then proceed to second line treatment and beyond after progression, which we would be discussing now. Next slide, please. Next slide, please. Second line patients, and the options of treatment that we have are chemotherapy, immunotherapy, FGFR inhibitors, and antibody drug conjugates. How we decide which one to choose depends on the first line treatment the patient has received, what are the residual toxicities of that treatment, what is the patient likely to tolerate in the next cycles, and of course, the presence of tumor mutations like FGFR. Next slide, please. So how we would be discussing is the patients who have progressed post chemotherapy and the patient who have progressed post chemotherapy and or immunotherapy. So the first set of patients are the patients who have progressed post chemotherapy. So these are the cisplatin eligible or carboplatin eligible patient who have received platinum in combination with gemcitabine and have now progressed to the second to receive the second line treatment. Next slide, please. So the NCCN gives a variety of options for these patients. For us to understand it simply, that is, if the progression-free interval after the first line treatment is more than 12 months, we should definitely consider retreatment with the platinum agent. But this should be done with the understanding that the patient is still platinum eligible. However, if the progression-free interval is less than 12 months or the patient is not platinum eligible anymore, then the options of treatment include immunotherapy, which could be PD-1 or PDL1 inhibitors like pembrolizumab, nivolumab, or avelumab, FGFR inhibitors like erdafitinib, and antibody drug conjugates like enfortumab vedotin. Next slide, please. Coming to the second line data of immunotherapy, we have 3 drugs. Pembrolizumab had a phase 1 data of only 33 patients, which showed a median overall survival of about 13 months, which was encouraging considering these patients were platinum refractory. Nivolumab had a phase 2 data of about 265 patients, and avelumab had a phase 1b data of around 250 patients, where about 20% of the patient received an overall response. The duration of response was about 7 months. The overall survival was about 8 months. But it was fairly well tolerated with very few grade 3 and grade 4 adverse events. Next slide, please. This Keynote 045 is one of the open label phase 3 studies of the use of immunotherapy in patients who had progressed after platinum based chemotherapy with an interval less than 12 months and were ECOG performance status 0 to 2, and they were randomized to receive pembrolizumab versus chemotherapy. The chemotherapy could be physician's choice between paclitaxel, docetaxel, of vinflunit. The primary endpoints of the study included overall survival and progression-free survival, while the secondary endpoints include the overall response rate and duration of response. As you can see in the slide on the slide in the right hand side, the overall response with immunotherapy was almost double as of chemotherapy. While in chemotherapy it was 11%, in pembrolizumab arm it was 22%. But more importantly was the duration of response. While in chemotherapy the patient had a response only for 4.4 months, it was up to 30 months in the pembrolizumab arm. And this also translated into a benefit in the overall survival and the progression-free survival. At 1 year, the progression-free so the overall survival increased from 30% to 44%, while at 2 years, the overall survival increased from 14% to 27%. So this, even at 3 years, the effect continued, the curves remained to be separated, and the effect of the overall survival remained to be doubled. The median overall survival increased by almost 3 months, which is significant considering these patients were second line and beyond and were platinum refractory. Next slide, please. Coming to the mutations, FGFR mutations are one of the mutations commonly seen in head and neck cancer, lung cancer, cholangiocarcinomas, endometrial cancers. But it is seen in a significant proportion of urothelial cancers. Urothelial cancers have 10 to 60% of the patients are found to have FGFR3 mutations, while 7% have amplifications and 6% have fusions. Next slide, please. Erdafitinib is approved for second line and third line treatment in advanced urothelial cancers with FGFR3 study, and this result is based on a phase 2 study where the patient who had advanced urothelial cancers who had progressed following chemotherapy were randomized, were given erdafitinib. The overall response rate was about 40%. The median overall survival was nearly 1 year, and the median progression-free survival was about 5 months. However, the drug has had an issue of tolerance, and almost 50% of the patient had grade 3 and 4 adverse events, and we would be discussing about the same in the further slides. Next slide, please. Next are the antibody drug conjugates. One of them is enfortumab vedotin, which is a fully humanized antibody, and it targets Nectin-4, which is a transmembrane adhesion molecule highly expressed in urothelial cancer. The second is sacituzumab govitecan, and it is a humanized RS7 antibody which targets TROP2, an epithelial cell surface antigen highly expressed in urothelial cancer. Both of them have been FDA approved in locally advanced and metastatic urothelial cancers who have been previously treated with platinum agent or and PD-L1 inhibitors in the neoadjuvant advanced and metastatic setting. Next slide, please. So for enfortumab vedotin, the study included about 600, it was a phase 3 study which included 600 patients randomized to receive enfortumab versus chemotherapy, and it showed an overall survival rate, it showed a median overall survival increase from 9 months to 13 months, and the median progression-free survival to increase from 3.7 months to 5.5 months. For sacituzumab, the study was a phase 2 study, which included about 113 patients with metastatic urothelial carcinoma, and it gave an overall response rate of about 27.4% with a median overall survival of about 11 months. Next slide, please. So we have pretty lot of options, though it might not be logistically feasible for Indian patients, for the patients who have progressed beyond chemotherapy, but the options are a little bit limited for the patients who have received either avelumab maintenance after chemotherapy or PD-1 and PD-L1 inhibitors, since they were platinum ineligible. Next slide, please. Of course, the options of FGFR inhibitors and the antibody drug conjugates remain, but the rest of the options of chemotherapy are limited. Next slide, please. Coming to the adverse events profile, the immunotherapy toxicity largely remains either dermatological or pneumonitis or autoimmune colitis, and the management is to continue the drug while giving symptomatic treatment as long as the toxicity is grade 1 and 2. But once it progresses to grade 3, we have to discontinue the immunotherapy agent and initiate corticosteroids. However, it can still be rechallenged. Once the toxicity progresses to grade 4, that means the use of further immunotherapy is contraindicated, and that thus discontinue it permanently. Next slide, please. The toxicity profile of FGFR3 inhibitors and the antibody drug conjugates is something which needs to be properly kept in mind, because it is something which is unusual. Erdafitinib is associated with hyperphosphatemia and ocular disorders, and hence we require to restrict the phosphate intake to 600 to 800 mg every day, and monthly ophthalmological examinations are required for the patients who are on the same. For the antibody drug conjugates, apart from the allergic reaction, dermatological toxicity is one, and once the patient is not able to stabilize on antihistaminics and topical steroids, we need to consult the dermatologist. Next slide, please. So summarizing my talk, the things are moving in a better direction. We have options for treatment of patients even after second and third line, which was seen in a very few patients before the era of immunotherapy. If the patient has received chemotherapy, then the options include immunotherapy, FGFR3 inhibitors, and enfortumab vedotin in the second and third line or beyond. However, if the patient has also received avelumab maintenance or PD-1 and PD-L1 inhibitors, as the patient was platinum ineligible to begin with, then the options include chemotherapy agents like paclitaxel, docetaxel, vinflunine, but the responses are limited. Thank you very much.
Thank you so much, Dr. Tandon, for taking us through the second line management of metastatic urothelial carcinoma patients. Ma'am, we will also have certain questions coming in during the panel discussion, which will be moderated by Dr. Amit Rauthan. And with that, maybe I also take this opportunity to invite Dr. Satish Domadia, who is a consultant and a medical oncologist at SCG Hospital, Ahmedabad. He has completed his training in medical oncology. Sorry, you are sharing your screen?
Hello. Yes.
Okay, great.
Yeah. Please do continue.
Thank you. So
I
he
was
has
just looking at
completed.
it. Yeah.
No worries, sir. He has completed his training in medical oncology from the prestigious Rajiv Gandhi Cancer Institute. He is also a ESMO certified medical oncologist and has many publications to his name. Dr. Satish has also special interest in the management of breast cancers, lung cancers, head and neck cancers, along with genitourinary cancers. With that, Dr. Dumaria, may I please invite you for your lecture, please?
Yes. Thank you, Dr. Hershey. And good evening, everyone. This is okay. Just a minute. Fine. Okay, so I'm here to present certain updates from ASCO GU 2023 regarding the management of advanced urothelial cancers. So this is actually the concise summary slide of everything what we need to be discussed. What options we have in managing any metastatic urothelial cancer? Obviously, we have chemotherapy, we have platinums. Apart from that, we have immunotherapy. So it can be the different combinations and permutations of these things. It can be, you can start with chemotherapy, give a maintenance avelumab, that can be one of the approach. The other approach is you start chemo plus immuno combination, you continue with the immunotherapy as a maintenance part, and then you consider second line management. Or you can just start with immunotherapy in cisplatin ineligible patients. So these can be various approaches of managing a metastatic urothelial malignancy. If you start with first line platinum containing chemotherapy, then what we expect is 3 to 5 months with first line chemotherapy, then a treatment free interval of 4 to 10 weeks, and then we give avelumab as a maintenance treatment, which gives us a median OS of 23.8 months. If you combine everything, what we get is close to about 30 months. So this is one approach which is certainly looking better than all the other approaches. Like if we are using immunotherapy as a second line treatment, we reach about 16 to 18 months. If we're using it from the beginning itself, combining it with chemotherapy and then continuing it as a maintenance part, then we reach about 16 to 17 months. So looking into this chart, the highest overall survival can be achieved by giving avelumab maintenance post first line chemotherapy. So Dr. Tushar Patil sir will be covering the updated follow-up data from the Javelin Bladder 100 trial. I'll be presenting some real-world evidences regarding avelumab. Some data regarding the trial IM-Viger 130, where upfront atezolizumab was studied. And lastly, in the platinum and the IO refractory setting, the role of the novel agents, sacituzumab and govitecan in Trophy 01 trial. So first line advanced urothelial malignancies, maintenance avelumab trial. So this is the trial where avelumab was used as a maintenance treatment post chemotherapy, and we now have a long-term follow-up data from this particular trial based on certain subgroups, which can be defined by the first-line chemotherapy regimen, and the analysis OS benefit with this is a reduction in the risk of death by using avelumab as a maintenance treatment post chemotherapy. So this is Avi Nance study. So it's a real-world study of avelumab first-line maintenance treatment. So it is important to see the real-world evidences as well, apart from the main trials, because trial can be a very controlled situation, controlled condition, and it is important to look into the real world evidence as how it is performing in the absolute world. So this actually looked into that. This is the baseline characteristics of the trial. Median age was about 70 years. There were 80% male patients, about 70 to 75% bladder malignancies were there, 20% upper tract malignancies were also there. Nearly everyone had a pure urothelial histology. There were certain rare variants as well. If you see the tumor status, the start of the first line chemotherapy, nearly 90-95% were metastatic to start with. The metastatic sites, these are the metastatic sites which are mentioned. The type of first line chemotherapy, you see 30% receive gem-cis and about 60% receive gem-carbo. So that is what is seen in real world study, that even that gem-carbo can be a common regimen than gem-cis in a metastatic urothelial malignancy management. Okay, so this is what I mentioned, that real world data are important since patients on the trial tend to be better than the patients in the routine practice. It is important to confirm the efficacy results of trials and to ensure toxicities that remain consistent with what was seen on the trial. So based on this particular study, the median PFS was 5.7 months. The median duration of treatment with avelumab was 5.8 months. The median OS in this particular study was 20.7 months. The subsequent treatment with the patients received, you'll see 80% they tend to receive chemotherapy as the most common regimen, most common subsequent treatment regimen. And about 11% received antibody drug conjugate, and there were few who received immunotherapies and other treatments as well. So this is a general chart which shows various treatment emergent and related adverse events. If you see the serious treatment related adverse events were seen in about 5.2% of the patients. And these are the various list of various treatment emergent adverse events which were noted. So it was concluded that the data for avelumab first line maintenance treatment in patients with advanced urothelial carcinoma are the first to be reported from the full analysis set of the ongoing real world evidence study, and they support the findings of the landmark Javelin Bladder 100 trial. Data from this trial also confirm the clinical activity and acceptable safety profile of avelumab first line maintenance in a large cohort of the patients from a heterogeneous population outside of a clinical trial setting. 1 year OS rate was 65.4%. The median OS was 20.7 months. The median PFS was 5.7 months. Safety profile was consistent. These results further support the recommendation of avelumab first line maintenance as a standard of care. There's one more real world evidence, and this is from the Italian compassionate use program. Many centers from this country were included in this analysis. So there was a prospective non-interventional study. So avelumab standard dose 800 mg was administered intravenously every 2 weeks. These are the various standard inclusion criteria and as well as the inclusion criteria. These are the baseline characteristics. 30% upper tract malignancies were included in this analysis as well. And here, if you see the chemotherapy regimens, here also about 50% of the patients, they received gem-carbo as the first line chemotherapy regimen. So median PFS in this analysis was 8.1 and the median OS was not yet reached. The 1 year OS rate was about 69.2%, very well corroborating with the landmark clinical trial. So it included a large population from 140 Italian oncology centers, and the results are obviously consistent with those of previous study. And the avelumab maintenance provided clinical benefits and had a manageable safety profile consistent with the Javelin Bladder 100 trial. Median OS not reached, 1 year OS 69.2%, median PFS 8.1 months. Clinical benefits were observed in population that included high proportion of patients who had upper tract malignancies or received carboplatin-based chemotherapy as well. So further, again, giving support of using avelumab as a maintenance treatment post-chemotherapy. So this is regarding the first line upfront use of atezolizumab with or without chemotherapy in advanced urothelial malignancies. And it was presented as an late-breaking abstract. The results from the phase 3 IMvigor 130 study, where atezolizumab plus chemotherapy, gem platinum, was compared versus only chemotherapy in the first-line management of advanced metastatic urothelial malignancy. And there were two abstracts which were presented. And if we see the overall conclusion was that it was a negative trial. So this combination of atezolizumab with or without chemotherapy does not seem to improve the first-line outcomes for the patients with urothelial malignancies, in line with previous combinations of checkpoint inhibitors with the platinum-based combination therapies. So overall, a negative study. That is what we can conclude. So this is the reason, or this is the data which shows that the approval of Tecentriq was withdrawal in managing advanced or metastatic urothelial malignancies. One important abstract was presented in this particular ASCO, and that was regarding the platinum and the IO refractory urothelial malignancies, regarding the use of sacituzumab govitecan. That's Prophy U01 study. There are various cohorts into that, and they included patients who were platinum refractory post checkpoint inhibitor. And what we can see an overall response rate about 30-35% in this difficult to treat group, because they're all platinum refractory, not responding to checkpoint inhibitors as well. So post multiple lines, there were certain cohorts where many median 3 or 4 prior lines were used. What you can expect is an overall response of 30%. I mean, median duration of response about 8 months, median PFS of about 5.4 months, and an OS of 10.9 months on using this antibody drug conjugate. Regarding the safety aspect, grade 3 and beyond treatment adverse events were seen in 65% of the patients, dose reductions in 40%, discontinuation in 7%. So this was a safety part of that particular trial. So to summarize, how to manage a metastatic urothelial malignancies, platinum, obviously they are important backbone. It is important to look into whether the patient is eligible for platinum or not. And if the patient is eligible for platinum, whether the patient is eligible for cisplatin or not. Cisplatin ineligibility doesn't mean that patient is ineligible for carboplatin as well. There may be patients who will be ineligible for cisplatin yet eligible for carboplatin. So that's an important thing to be understood. So if a patient is cisplatin eligible, first line treatment will be Gemcis, 4 to 6 cycles, followed by avelumab maintenance if the patient is not progressing. The patient is cisplatin ineligible and carboplatin eligible, then the first line regimen will be Gem Carbo, 4 to 6 cycles, irrespective of the PD-L1 status, obviously. And if there is no progression, then switch to avelumab maintenance. If the patient is platinum ineligible, only then there is role of single agent pembrolizumab, or to use any non-platinum single agent chemotherapy or best supportive care. And as mentioned, there are various specific criteria in choosing whether the patient is eligible for cisplatin or not, whether the patient is eligible for carboplatin or not. Galski's and the Gupta's criteria are there. So that's the summary of the presentation. Again, thanks, Mark, for giving this wonderful opportunity, and over to the organizers. Thank you.
Thank you so much, Dr. Dumaria, for that session and from the recent data which was presented at ASCO GU. With that, it is now also my privilege to invite and introduce Dr. Tushar Patil, sir. Dr. Tushar Patil is a consultant in medical oncology at Sahyadri Hospital, Pune, with more than 12 years of experience in medical oncology. He has also been the gold medalist in DM oncology from the Gujarat University in 2009 and has been a co-investigator in multiple clinical trials. He has special interest in immunotherapy, targeted therapies, medical and oncology. And with that, let me please invite him for a session on long-term survival in advanced urothelial carcinoma, unraveling the recent data from Javelin Bladder 100 at the ASCO GU, and also share his clinical case with Evolumab in the first-line maintenance. Dr. Patil, may I please request you if you can share your screen and start your session?
Should I start with am I audible?
Yes, sir, you are audible and will be able to.
So good evening all. I think this drug has clearly established its efficacy, and long-term data is there with this drug for the management of the metastatic urothelial cancer. And we'll just go through the slides that will depict its efficacy and the tolerability and the safety profile of this drug. I think we all know that switching from a first line to a second line to third line in almost all cancers, the patient dropout rate is quite high. And by the time they reach a second, third, or subsequent lines, hardly 10 to 15% patients are able to sustain beyond this. So this is what also happens in metastatic urothelial cancer, from 100 to 48 to 79 to 6% who receive third line treatment. And if we see the eligibility criteria, I think the previous speaker has already pointed about it, that cisplatin and carboplatin is what are the main drugs, out of which cisplatin can be used in almost 60% patients. And out of the patients who are ineligible for cisplatin, then around 75% do receive carboplatin as the other, what we say as drug in combination with gemcitabine, which is the standard of care. The selection of drug depends on the performance status, the cardiac function, the renal function, the existence of neuropathy, comorbids, age, how much fluid can we give to this patient. All these do decide the factors that we rope in for our management and the decision making for carboplatin versus cisplatin. As we see, there are various criteria that we can utilize, and we have our own measures to do that. Definitely, both these drugs are acceptable. For patients who are platinum totally ineligible, both cisplatin and carboplatin immunotherapy upfront can be given for these patients without any hesitation, and it does work well. The strategies which we evaluated to extend the survival in this patient, first was to complete your chemotherapy and wait and watch. Second was continuation of the maintenance. Third is switch maintenance, which we'll be talking about in the subsequent slides. So wait and watch policy after disease progression. From the stop of first line chemotherapy, you initiate the second line treatment. Switch maintenance is somewhere where you do give chemotherapy for a fixed duration, followed by patients who are tolerating well and responding well, switch to a immunotherapy, a second drug maintenance, which is immunotherapeutic maintenance. And upon the second the progression, then we switch to a second line treatment. And continued maintenance will be a combination of chemotherapy plus IO and then an IO maintenance, and on disease progression, second line treatment. We all know that the 50 to 80% of the patients who achieve control with platinum-based chemotherapy, but the OS is still something which is not very good. As we can see, the OS with cisplatin-based treatments around 14 to 15 months, and carboplatin-based chemotherapy 13 to 14 months. That has been the OS that we are seeing. There has been various trials of using various immunotherapeutic drugs in combination with chemotherapy, and almost all of them did not yield the result that they were meant for. The MVigor 130, there was no significant difference in the OS. The Keynote did not meet the OS or the PFS criteria. The durvalumab tremelimumab did not again meet the OS in points, and the pembro plus lenvatinib was again a negative trial. Amongst the switch maintenance, I think Javelin was the only trial which showed a significant benefit versus no maintenance, regardless of PD-L1 status, regardless of the partner drug, whether it was carboplatin, cisplatin, regardless of how many cycles were used, whether 4 cycles or 6 cycles, all those parameters which we will be discussing in the subsequent slides. So this was the trial, a phase 3 randomized open label study. Patients unresectable at locally advanced or metastatic urothelial carcinoma with a measurable stage 4 disease who had received 4 to 6 cycles of chemotherapy, cisplatin or carboplatin plus gemcitabine, and who had a non-progressive disease. So they had achieved a CR, PR, or a stable disease. The typical immunotherapeutic drug, avelumab, was started after a treatment-free interval of 4 to 10 weeks when there was a radiological assessment. And this was compared to best supportive care, the primary endpoint being overall survival, and analysis population being all patients, PD-L1 positive patients, and the secondary endpoints, of course, being PFS, the response, time to response, disease control, response duration, safety, tolerability. And we can see 68 years was the median age, almost 76% were males, 24% females. Almost all of them were very good performance rate of 0 and 1. So visceral metastases were present in almost 55% of the patients. And as we can see, again, cisplatin was used in almost 50 to 55% patients, carboplatin in 42% patients. If we see the median OS, avelumab plus best supportive care gave us 23.8 versus best supportive care only 15. So the risk of death was reduced by 24% in the avelumab arm, and 50% of the patients in this arm is still alive at even 24 months. This OS was longer as compared to best supportive care across all specified or pre-specified subgroups, being age, response to chemotherapy, number of cycles, males or females, race, PD-L1 status, what was the chemotherapy partner drug or chemotherapy regimen which was used, liver lesions if they were present at baseline or no at baseline. All these parameters taken into account, the avelumab maintenance scored over. In the overall population, the risk of disease progression or death was reduced by 46% in the avelumab arm. And it was across all specified subgroups that this effect was seen. The JB100 data from ASCO GU 2023, I think avelumab plus best supportive care, the OS here again is impressive 29.7 versus 20.5 months. In the subset of this patient eligible for the Javelin study, that is no progression on the first line chemo, OS from the start of chemo was 29.7 months. This has been already discussed. To conclude, the long-term follow-up of this provided a data which established this drug as a more efficacious drug as compared to best supportive care for the OS and the PFS benefits, irrespective of whether the patients have received a standard of care first line cisplatin or carboplatin. And the median OS with the full Javelin bladder regimen was 29.7 months. OS was longer with avelumab, irrespective of the first line regimen, chemotherapy regimen used. Also support further use of this drug as a standard of care in patients with advanced urothelial cancer who are progression free following the first line treatment. This was again the subgroup analysis, which was the Asian subgroup analysis, and it did show again a median OS of 28.7 months as compared to the supportive care only of 18.2 months. PFS again 5.6 versus 1.9 months. So the treatment related AEs and the safety was proven beyond doubt. There was a good tolerability and a safety profile of this drug. The as we can see, the grade 3 or more AEs were only in 50% of the patients, and these are the commonest AEs that we can come across: pyrexia, nasopharyngitis, constipation, arthralgias, rash, UTIs, vomiting, and transaminitis. Immune-related adverse events of any grade occurred in 23% patients, that is 31.9 in the avelumab arm. We apply the results of this in clinical practice, and we can see 4 versus 6 cycles of chemotherapy did not matter. Carboplatin versus cisplatin did not matter. The response to treatment, whether it was CR, PR, or stable disease, did not matter when we were using a switch maintenance to of immuno-oncology drug avelumab. So 4 cycles were good because carboplatin was as good as cisplatin if the IO maintenance was used, and of course the response also, even if it was a non-progressive disease, it was sufficient. So this was if we used 4 cycles, in the OS was 19.9 versus 13.7 months. If there were 6 cycles, 24 versus 14 months. And irrespective of the response that we have, CRPR or stable disease, the patients were responding once they were switched to immuno-oncology drug avelumab. Benefit was also seen irrespective of the duration of the treatment-free interval before maintenance. So OS was prolonged with this drug as compared to best supportive care, irrespective of the treatment-free interval of between 4 to 10 weeks. That was seen. Sequence of therapy in the second and subsequent lines post avelumab, I think, yes, there are other options which we can, a platinum-based or paclitaxel-based, or sometimes DDM pack would be used if the patient has that good tolerance beyond in the second line setting. And of course, for mutation analysis and HGFR, we have these inhibitors, which Madam has already talked about. The what we say as summary of what second line treatment patients received, many times re-challenging with the platinum-based chemotherapy, immuno-oncology drugs like pembrolizumab, atezolizumab, or ribulizumab, and other anti-cancer drugs like vinflunine, paclitaxel, enfortumab, gemcitabine, docetaxel, so on and so forth. So, OS in avelumab arm by the type of the second line treatment, again, it showed a consistent benefit where this avelumab was discontinued with no second line treatment. There was an OS of 18.2 months. Discontinued avelumab and received a second line treatment. There was almost a 19.9 months. Re-challenging with second line platinum-based chemotherapy, 22.5 months. And any other second line anti-cancer treatment, almost 19.1 months. These are the guidelines that we are actually using. So many drugs to use for, and beyond the second and the third line, it is depending on the patient tolerance and performance and the oncologist's preference also, which will definitely matter. This is beyond the second line, which Madam has already talked about. For select FGFR selected patients, ardafitinib and enfortumab, sacituzumab being there, another drug, showing responses of the OS of almost 13.8 months in ardafitinib, and enfortumab almost 12.3 months and 16.3 months for the sacituzumab. So this is the drug approved for patients with metastatic urothelial cancer with FGFR mutations, following progression on the prior chemotherapy, where the median OS was initially 13.8 months, and after 24 months followed on to 11.3 months of long-term data again with this trial, showing ORR of almost 41.3, and as compared to any other chemotherapy, 18.6, median PFS of 5.55 versus 3.71 in the enfortumab vedotin versus chemotherapeutic arm. Median PFS, all patients 5.5, and subcriterion as per the lines of treatment, prior immunotherapy or prior chemotherapy is being divided. These are various immuno-oncology drugs also which have come into this. Pembrolizumab as a third line or a second line. The treatment continued for almost 2 years or until progressive disease, unacceptable toxicity, or withdrawal of the consent. And as we can see, this trial design showing an updated overall survival where median OS in the pembro arm is 10.1 as compared to chemo, it's 7.2, a hazard ratio of 0.71. Pembro did prolong median OS of all patient subgroups which were analyzed. Updated PFS did not show any real improvement. The hazard ratio is not significant at all. If we go for the guidelines or the clinical practice, what we follow for patients with cisplatin eligibility, we go for 4 to 6 cycles of this drug combination followed by avelumab maintenance. For patients with cisplatin ineligible, gemcitabine carboplatin again for 4 to 6 cycles followed by an immuno-oncology avelumab maintenance, and patients who are platinum ineligible, either they go on for a best supportive care or a pembro as a single agent or a non-platinum single agent chemotherapy. Various criteria is being used for this, and this is what if we judiciously choose our drugs and the sequence that we follow, the projected OS that we can achieve with various combinations, where I think first line chemotherapy followed by treatment-free interval and an immuno-oncology drug, avelumab maintenance, gave us a maximum OS of almost 30 months as compared to any other sequence or a combination. To conclude, long-term follow-up of the Javelin Bladder 100, which is more than 2 years in all patients, continue to show prolongation of OS and PFS with this avelumab plus best supportive care versus only best supportive care. both among all randomized patients and those with PD-L1 positive tumors also. OS rates at 2 years were 49.8% in the avelumab arm versus 38.4% in the best supported alone arm. The 2-year PFS was 23.4 versus 17 months, respectively. OS was prolonged with this drug maintenance despite a high proportion of patients treated with best supportive care alone receiving a subsequent anti-cancer drug therapy. OS was prolonged with this drug, avelumab, irrespective of the first-line chemo use, irrespective of the number of chemo cycles, 4 or 6, irrespective of the PD-L1 status, positive or negative, and irrespective of the response to chemotherapy, whether it was CR, PR, or stable disease. The long-term safety profile of this drug, avelumab, was consistent with previous monotherapy drugs studies, and no new safety signals were identified. So I think in clinical practice also, yes, definitely it is a drug which we have ourselves experienced and is working for many of our patients. So that's the end of my presentation, first presentation. Over to the organizers.
Thank you so much, sir. If I can also request you if you can share your case.
Yeah, I'll do that.
Thank you.
So again, I had this opportunity to share this case, very interesting case. So he's a 33-year-old male who had symptoms of hematuria and bone pains and weight loss, loin pain also. When he came in 2021 to us, CT, there was an ultrasound done initially which showed some bladder mass, and then CT urography showed a vesical mass with a perivesical extension, involvement of the right VU junction, pelvic retroperitoneal inguinal nodes, and of course retroperitoneal vessels. And because of the back pain, we had done an MRI which did show bone metastasis or lighting lesions also. Histopathology after a DURBT was high-grade urothelial malignancy without lamina propria invasion. This histopathology was confirmed from a second pathologist and with the immunohistochemistry. Subsequently, a PET scan did show mass with scattered lung nodules. So it was a day 1 carcinoma urinary bladder metastatic high grade to begin with. Because he was a young patient and good performance status, as well as normal creatinine, apparently no prior exposure to any of the drug which could cause neuropathy, no comorbids. He was the right candidate for being a cisplatin eligible, and he was subsequently put on gemcitabine and cisplatin. This patient was, after 2 cycles, evaluated with a repeat scan, which showed a significant partial response. The same response was maintained even at 4 cycles because he continued to respond to chemotherapy even beyond 4 cycles. He was given a total of 6 cycles of chemotherapy of cisplatin and gemcitabine. The last 5th and 6th cycles, he did have cytopenias, and there were some 1 or 2 weeks delay of the chemotherapy. At the end of 6 cycles, his scan was really in significant partial remission. At this time, the option of maintenance of avelumab was discussed with him, and he readily consented to using the drug for maintenance therapy because it was non-progressing, and this patient then subsequently received the avelumab maintenance. So this, as we can see, the pre-CT and the post-chemotherapy scans, definitely there was a very good response in all the sites that he had to begin with from day 1. This was as per the Javelin data that we switched him to the avelumab maintenance. This drug was given at 800 mg every 2 weeks, which started, this chemo got over in December, and then after 4 or 6 weeks, we started on the avelumab maintenance. Sorry, for him, we had initiated 2 weeks after the completion of chemotherapy, not 4 weeks. His chemo had got in 3rd or 4th week of December. He did not have any residual toxicities because of chemotherapy. That was the time when we had initiated. The scans at 3 months of avelumab did show a continued phase of response to avelumab drug. In the month of April or May somewhere, he developed some bladder. He had a hematuria, one episode. Ultrasound did reveal bladder lesion, which was small, but it was what we say as suspicious. Subsequent TURBT was done, and uh, this revealed that there was a low-grade urothelial component which was coming up. This low-grade component was reviewed by a second pathologist in Pune, and subsequently the same slides were reviewed by Tata Memorial Hospital pathology department. Uh, it confirmed that it was a low-grade urothelial malignancy, and this time there was no recurrence of a high-grade urothelial malignancy. The same case was discussed with TMH, of the uro-oncology division, and they opined that because there is no evidence of any high-grade urothelial malignancy coming up anywhere in the body, including the bladder, we could treat the low-grade malignancy with the help of intravesical therapies and continue to use the avelumab for the prevention of any recurrence of the high-grade component. So this patient continued to receive avelumab, and he underwent TURBT and intravesical therapies. Initially, the intravesical therapies were epirubicin and BCG based. Subsequently, the intravesical therapy, as per the TMS protocol, was switched to gemcitabine and docetaxel based. September 2022, a PET scan was done, which showed a reduction in the size and metabolic resolution of the previously seen bladder wall lesion. And still, there were no new lesions anywhere in the abdomen, pelvis, lung, liver, bones, anywhere. He was continued on this avelumab. There was a recent scan in the month of February, which did not show any FDG-avid local regional recurrence locally as well as distant organ involvement. The patient is still continued to receive avelumab 800 mg, and his next cycles, I think, will be due. Next evaluation will be due somewhere in the month of July or August. Till now, the patient has done well, responding to the treatment with good tolerability and hardly any treatment-related adverse events seen. He's completed 32 cycles in 16 months of avelumab till date. So this is one patient, young patient, who to begin with was metastatic urothelial malignancy, responded well, then relapsed with a low-grade urothelial malignancy component, which was tackled locally with the component, is still under control, even at almost 2 years from the start of the treatment for the high-grade urothelial malignancy. Thank you. Thank you. That's all for this case.
Thank you so much, Dr. Patil. Maybe with that, I also take this opportunity to now invite and introduce our moderator, Dr. Amit Rauthan, sir. Before we move into the panel discussion, Dr. Amit Rauthan is the HOD and consultant in medical oncology at Manipal Hospital in Bangalore. Sir is also the member of ASCO, ESMO, American Society of Hematology, the member of Indian Cooperative Oncology Network, ICON. Sir has also received the Times Healthcare Achievers Award in Medical Oncology in 2019 and has authored and contributed to more than 50 renowned research publications and contributing significantly to cancer screening programs. With that, sir, may I please invite you to take over the proceedings for the panel discussion?
Thank you, Dr. Harshveer. Good evening, everyone. Thank you, Mark, for this opportunity. Could you share the slides?
I'll do that, sir. Definitely. Sure.
So we had we heard 3 excellent talks from about the management of metastatic urothelial cancer. So what we'll do quickly is just get into clinical practice, because we've seen the data now. And so let me just start with Dr. Tushar because of his case. That's an excellent case, Dr. Tushar. So just one quick question. How long are you going to continue avelumab?
So I think 2 years is what I would like to continue for. Yes.
And if he continues to do well, you'll stop or will continue?
I will counsel him for further avelumab. Right now, what we have done is we've changed the strategy. Instead of 2 weeks, we are giving you avelumab at 4 weeks interval. This was discussed with Tata Memorial Hospital team. And then they said that, yes, okay, at certain point of time, patients, even at lesser, further intervals can be increased and the same benefit can be achieved. So last 4 months, he's been receiving avelumab at 4-week interval, not a 2-week interval.
Right. I agree. So there's no right answer there, and there's only thoughts all of us have. But I think one thing about Javelin 100 is it's done indefinite avelumab, and that's
True.
always a question which comes in our minds. Our patients are doing, if they're doing very well, 1 year, 2 years, indefinite, and that's something we learn as we go through more and more patients in clinical practice. But I think
True.
excellent patient, because you've finished a year of avelumab, that's also wonderful, and you're moving forward. And I think this is what we do many a times in practice of what you are following. Okay, so let's quickly get to the discussion. Just we'll move forward. Next, please. Or can I control the slides? Yeah. Okay, no problem. I think let's move forward just quickly. Yes. Okay, I don't think I can control it. Right. Okay. So Dr. Kshitij, in your practice, first line therapy, how many cisplatin gem I know is your standard of care, but how many patients do you really see who don't tolerate cisplatin gem, and what do you do for those patients? And we can have the next slide.
Okay. So, sir, what we generally see is about 30 to 40% of the patients will be such that who are ineligible for cisplatin. But I think there will be only 10 to 20% of the patients who will be ineligible for carboplatin as well. So this is what we generally see, sir.
Okay, so your go-to regime is carbo when your patients can't get cis.
If they can't, yes, cis. But first choice will be cis. But if not eligible for cisplatin, then gem carbo. Yes.
Right. Okay. So, yeah. So I think in practice we are seeing quite a lot of this of gem carbo usage in our patients. Dr. Tushar, your percentage of patients who are on gem carbo versus gem cis?
So I think gem carbo is equal, like 50% of the patients are on carboplatin, 50%. For one or the other reason, if the bladder tumor is involving the VUJ, if there is a obstructive component, if the creatinine is a little high, patients usually have an element of cystitis or a UTI also, which raises the creatinine. And at least initially, it becomes very difficult to use carboplatin, cisplatin for many of our patients. So half of them on cisplatin, half of them are on carboplatin.
Right. Yeah. So I think that's the way it is. A lot of our patients, we are comfortable using even carbo nowadays. Earlier, we used to be very hesitant. Dr. Nidhi, Dr. Nidhi is there? I don't see her. Okay. I don't think. Okay. This was a consensus statement, the Delphi consensus method, which was published recently by all the many Indian investigators led by Senthil Rajappa, and they gave a good consensus statement of cisplatin and carboplatin eligibility. And this is something I think all of us in various forms follow in clinical practice. But yes, GemCis is the standard of care, but patients who don't tolerate GemCis, we would try and say gem carbo could be an option. Recently, there's the new data set. Dr. Tushar, do you have any thoughts of, though we don't have it in India, but Pembro EV for patients who are platinum ineligible, cisplatin eligible, or platinum eligible? There's the new data of EV plus Pembro, which is really getting very exciting. And many people are talking about that for patients who may not tolerate platinum. Any thoughts?
I think it may be immuno-oncology as a single drug, yes, definitely can be done. And this will need to be in a larger population, more data to come in. But yes, these are all exciting data. Every 1 month we are getting an exciting data every oncology indication about immunotherapeutic drugs.
Absolutely. You're absolutely right. The way the data is changing.
Yes, they have moved from metastatic to palliative to adjuvant to neoadjuvant, and patients who do not achieve a CR after your entire treatment, they can be eligible. So fantastic data.
No, excellent. I agree with that. In bladder cancer, the way we are changing the whole treatment paradigm, we're just moving up and up. I actually found that data very exciting, because when we don't have platinum eligibility, Pembro EV is what they are looking for. But again, that is for that very selected patients where it was not platinum eligible patients. So again, exciting data, but it's not an approved recommendation at all. And of course, for us, we don't have EV in India, so that's something we can't use much at all. Next, please. So I think next, please. Next. Yes. So I think all of us have kind of accepted the paradigm of induction chemo, GemCis or GemCarbo, and then all of us are talking to our patients of avelumab maintenance. Dr. Kshitij, your experiences with this, Tushar shared his experience also, your experiences with this kind of an approach.
Yeah. So definitely looking at the data, definitely looks promising. Looking at my personal experience, I have only one patient experience with avelumab. Post gem carbo, he was shifted to avelumab. At the end of 6 cycles, he progressed. So that was my personal experience with avelumab as of now. But looking at the data, definitely looks promising. It makes sense to use something as a maintenance treatment in an aggressive malignancy like high-grade urothelial malignancy, rather than reserving these agents to use it as a second-line treatment. I think that makes much of a sense to use it as a maintenance if the patient is affording for that, rather than to reserve it as a second-line treatment. It makes sense.
Right. I kind of think all of us, again, we do worry that these patients are very aggressive diseases and some of them will progress the way you have seen.
Right.
And some patients progress, but we keep hoping most will not progress and will get on to avelumab maintenance, and using maintenance is definitely the way forward. Next, please. I kind of always get little surprised whenever I see the IMvigor 130 and the Keynote 361. You know, it kind of perplexes me sometimes. Why would a chemo immuno combination followed by immuno maintenance not work? And it clearly doesn't work. And we've seen now 2 big trials. So we know that we cannot really say we would use chemo immuno for a patient, say that we'll better get responses, higher responses like we do in lung or head and neck or other cancers. This is clearly doesn't work. And it's always a big surprise. Tushar, your thoughts on this? Using this kind of combination upfront?
I think a lot of immunotherapeutic drug will depend on efficacy, will depend on how the tumor microenvironment is, and probably that needs to be studied for the in a deeper manner to know whether immunotherapy in combination with chemotherapy is going to work. So we still are not into that deeper understanding of the combination, how it works. For some cancers it is working, some cancers it is absolutely not working. So I think that needs to be tumor microenvironment and the antigen release and the way it responds to immunotherapy is what needs to be understood.
Yeah, absolutely. We really don't know what is the microenvironment as you are talking about, and that's absolutely, I think.
So initially we thought that lung cancer PD-L1 is one of the markers that we will be using for giving immunotherapeutic drug. But today we know that irrespective of PD-L1, we will be able to use the drug in combination with chemotherapy, and in second line definitely, even if the chemotherapy fails. So many things which we still don't know.
Yeah, absolute. I think there's a lot more we need to understand. We really don't know why. But in bladder cancer, at least, we are convinced that we should not be doing a combination of immunochemo and hoping that will give us better results. I think the sequential switch maintenance is the best way as of now for bladder cancer, which is giving us the best, longest survival. A word on PD-L1. Kshitij, Tushar mentioned this. Do you think about doing PD-L1 any times in bladder cancer or any other biomarkers in the metastatic bladder cancer setting?
Right. Not really, sir. Not really in bladder cancer. As clearly shown in this particular analysis, that atezo plus chemo or pembro plus chemo, that's not a way forward in bladder cancers. And the only good evidence we have is of avelumab, and that has nothing to do with PD-L1. So I don't think so it makes sense to use PD-L1 before choosing any IO agent. The only thing where we prefer giving IO is, I think, in ones who are ineligible for any platinum, either cis or carbo. I think, and that can be given irrespective of PDL1, because there the biology is bad and we are short of options. I don't know whether to choose between any novel agent versus IO. PDL1 will be helpful or not, but I don't think so. As of now, we routinely tend to see for PDL1 before giving IO.
Yeah, I fully agree with you. So PDL1 has not really played much role in bladder cancer, though there was that earlier talk, and earlier we used to talk about it a little bit, but again, there is really nothing now of importance of PDL1, at least in our maintenance setting. There is some subgroup data we have seen long term from IMVIGA 130 showing the high PDL1. There is the slight benefit in the survival. So though we say overall it's a negative trial, but in the high PDL1, but because of the hierarchical analysis and the way the statistical analysis was, they cannot get to that also. So clearly, PDL1 is not playing that much of a role for us in bladder cancers as of now. When do you do NGS testing, Dr. Tushar, for your patients in bladder cancers in the metastatic setting?
So I think not as a routine, but maybe beyond second line, yes, definitely, if the patient performance status permits.
Yeah, so second line is definitely there, right? So we are all.
So I have another interesting case, if time permits. Can I? So
yes, sure.
This patient is a 84-year-old gentleman who had a bladder high-grade malignancy, a loco-regional disease to begin with. We gave him neoadjuvant with the hope that he would improve, and then he will get convinced for a surgery. He was not willing for surgery. So radical chemoradiation was given to this patient. Within 8 to 9 months of completion of radical chemoradiation, he relapsed loco-regionally again. So still not metastatic anywhere, and not willing for any local treatment in terms of surgery. So this patient has been on chemo and maintenance. He was again not willing for avelumab or any other immuno-oncology drug maintenance. This patient has been kept on carboplatin maintenance. This is almost 2.5 years. 84-year man, 2.5 years. The relapse was treated with paclitaxel after 1.5 years. He responded to that. And then again, carboplatin has been initiated. So it's been almost 2.5 to 3 years now that we are playing around with him, giving him all the options. He is not willing for any radical surgical or treatment which will cure his disease. He said, my chemo is working for me. Let me take the chemo.
No, absolutely. He's a platinum sensitive patient. That's the best thing about it. So I think that's a wonderful way of taking him to long-term management with
plus
platinum.
84, at the age of 84 he's doing.
No, absolutely. I think we sometimes get these wonderful patients who respond and who understand their disease and who want to take it further that way. And I think there's nothing better than that, the long-term treatment with chemotherapy. So that's something we do debate about in patients who respond. How much chemo can we give them before we get to maintenance? But yes, in at least in the general population, we try to restrict ourselves to 4 to 6 cycles. I think that's what we all do.
All we do.
And we know the toxicities of chemo will add up more and more as we try and do more and more, and we try to get to maintenance. Next, please. So I think we've covered everything of those aspects. We saw all of the data sets. So next, please. Yeah. So I think the most interesting part is this. We are increasing survival of patients. There's really no doubt about it. We used to talk about 2-year survival of 20% 20 years back, and now we are talking of 2-year survival of 50%. And with immuno, we may get that tail of the curve, and we are definitely going to get into 3 years, 4 years, 5 years survival percentages, which are much higher. And that's the whole exciting part of immunotherapy.
Sure.
Next, please. Okay, I think we all discussed the data talking about from the start. Next, please. So we saw the real world data. Kshitij presented this, and we also kind of accept this is what it is from all the guidelines. So this is our Indian guideline. This will be what all of us will be quoting, and I think all of us are quoting exactly the same thing as the international guidelines. So I don't think this will be too controversial. Bladder cancer has metastatic setting, at least first line, has become non-controversial. everyone agrees and everyone is on the same page. We will do chemo and switch maintenance. And I think that's something that all of us are happy about. Uh, uh, let's quickly word about toxicity. Have you experienced with avelumab, Tushar? You have used it in a few patients now. Any toxicities?
No, nothing of concern actually, except for maybe some infusion-related reactions sometimes, but actually no, nothing of concern. We've had toxicities with other immuno-oncology, but not with that.
Yeah, that's also been our experience. Though my experience is very limited, a few patients of bladder, few of RCC. But as of now, till now, even we have not had much toxicity with avelumab. Again, that whole debate comes whether it's PD-L1 versus PD-1. Possibly, is that the reason why you're seeing lesser toxicities with avelumab? But again, I think as we do more and more, probably that we'll learn whether there are toxicities which are different or not. Kshitij, any experience not of avelumab toxicities? You did mention one patient there, but any
Right.
other patients or something?
No, not specific. Not any specific eye-related toxicity was seen in that particular patient. Generally, I think in the entire IO era, definitely in few of the patients, in about 10 to 15% of the patients, there are some concerning toxicities, and I think we need to have a strong clinical suspicion about that. That fatigue is something very disturbing. Sometimes you may have a rare incidence where the patient is actually breathless in a time reaching into emergency ward. Everything is normal. There's no sign of any infection. You give steroids, it settles down. But this is commonly seen in this era. I don't know whether this is actually related to it or not, but this is generally what we see. Some patients do have some very specific toxicities which needs a special attention to that. That's it.
Absolutely. I think a point well made. 10% of patients can develop severe toxicities to immunotherapy. So though we say most patients, nothing will happen, we need to be always on a constant vigil and be careful. We sometimes become very complacent because most don't have any issues. So we should be a little careful. We may rarely get patients with toxicities, but most patients tolerate very well. Finally, moving on, I think we discussed this, that we are moving forward and upward. And as we move upward, Tushar, you will come to a stage where you will use, I'm sure, nivolumab as adjuvant for your high-risk bladder cancers.
As I said, so it will come up sometime.
So it will happen. So now, when these patients metastasize, what are your thoughts? What are you going to do, and how are you thinking about it? Because it will start very soon. We will be doing this, I know.
So you mean to say, ask a patient patient is on maintenance avelumab and then progresses?
No, what I mean is they got operated for a high-risk bladder cancer, got adjuvant nivo, and then progressed.
Okay, so I think for them, definitely chemotherapy would be the option.
And would you follow it up with adjuvant avelumab, with the switch avelumab?
So this is very difficult to say. If the prior disease-free interval with nivo has been good, then possibly yes.
Yeah.
The same that we apply with other targeted therapies like the Vasumab or something.
Right. So this question is now coming up for us even in RCCs and even in bladder cancers.
Correct.
Our thoughts are, we will probably, all of us thinking the same way. Maybe if we gave adjuvant and they relapse after a certain amount of months, then probably we'll be comfortable re-challenging them in the switch maintenance setting. But again, this is something that is so new, though we are writing, everyone's writing sort of guidelines that this is what the approach should be, but no one knows the right answer. And I think as we generate more data, everyone will sort of start.
It's like your RCC patient. You put him on sunitinib and the patient has progressed after 3 years. You will probably switch to another oral anti-angiogenic drug, but the patient progressing within 6 months, probably you would like to change the mechanism itself.
Right. Absolutely. That's the way it's going to be. Kshitij, if you gave a metastatic setting chemo, got good response in the metastatic setting, put your patients on avelumab maintenance, and then they progress on avelumab, what are your thoughts on those group of patients nowadays?
Right. Okay. So IO post-IO definitely is an emergent concept, and that's where the importance of disease-free interval or progression-free interval comes into picture. While on avelumab, if the patient is progressing, I think we would not be very keen to give a different checkpoint inhibitor. In such a scenario, probably a different line of chemo probably any other newer molecules can be tried, but certainly not a checkpoint inhibitor just if the patient is progressing while on avelumab. Giving adjuvant nivolumab, obviously, if I'm having any specific disease-free interval, obviously you can again re-challenge with it with IO, definitely. Yeah.
Right. So patients on progression on avelumab, definitely we will need to stop the IOs completely. As of now, we go to chemo because that's the only option available to us freely in India. Though the data of EV is very exciting and SASI, the data is exciting. We have had a couple of patients where we have experienced good responses with EV after progression on chemo, immuno, and chemo after that. So 3 lines of therapy and EV has worked again. And we have a patient who's actually crossed around 8-9 months of EV and doing well. We've seen SASI also. We have another patient who's crossed 6-7 months of SASI on progression of chemo immunos. So slowly ADCs are making their space. There is really no doubt about it. ADCs are coming into the space and ADCs are moving up. But again, this is only late progressions is where it is possible. A word of FGFR, I don't know. Our experiences have been a little limited. We have done a limited amount of NGSs in bladder, but our FGFR alterations have been a little lower than what was reported from the international literature. But again, I think maybe it's just because the number has been less. So I think once we start doing more and more sequencing, our FGFR mutations and fusions will be picked up much more. And probably those are the ones for erdafitinib, if and when erdafitinib comes to India. So I don't know that's when that's going to happen. Otherwise, taxanes, that's the go-to regime for us, and taxanes work well. I'm a big fan of weekly paclitaxel or nab-paclitaxel in bladder cancer in late lines, and I think it's a good drug when patients progress on other lines of therapy. So probably with this, we will conclude. We have clear paradigms for management of bladder cancer, and we are learning and we are adapting very rapidly. I think it's a very, very exciting space to be in. I think it's a very exciting time for how we are managing our bladder cancer patients. And as Dr. Tushar mentioned, you adapt and you do different things for your patients in India for different circumstances. But we are seeing how avelumab has made a clear indication there. So this is one of those non-controversial places, where avelumab has become a clear switch maintenance, which we did not have with any other form of it. So I think with this, I will conclude. There's just one last question which is put up there in the chat, which is very interesting. Dr. Tushar, will you take that? Do you differ in your upper urinary tract cancers management?
So metastatic? No, I don't think so.
No, right? But
No.
the data is getting a little tricky because the results from the upper urinary tract, if you see, are not as good as lower urinary tract.
I know, they tend to be more aggressive and biology-wise.
Correct. So a lot of thoughts whether they differ in terms of biology or they differ in terms of many different things. So that thought keeps coming up. But I kind of agree with Dr. Tushar here. I don't change my management as of now, but I believe that's the best we can do. So we would still do the same chemo followed by avelumab maintenance for this kind of setting.
2023, I think we'll still do the same.
Yeah, correct. I think that's well put. After next year, it may be something different, but as of now, it's the same exactly. So thank you very much for this, and thank you, Tushar, thank you, Kshitij, and thank you, Mark, for this opportunity. Thank you.
Thank you so much, sir. I believe well on time. Thank you so much for that. I believe this was a very interactive session. A lot of clinical questions that you posed across this clinical nuances for management of metastatic urinary bladder cancer would have been helpful for the participants and the audience overall. Just a small request for the audience online. We will request you all to please put in the feedback on the portal so that we can modulate, modify, adapt to further sessions in the coming time. With that said, I also now take this formal opportunity to thank all our faculty, Dr. Amit Rauthan sir for moderating the session, Dr. Tushar Patil, Dr. Kshitij Tomadia, and Dr. Nidhi for their excellent sessions, the lectures, Dr. Patil and Dr. Domadia for also participating in the panel discussion, sharing their clinical insights, sharing their cases along with Dr. Rauthan. With that, thank you once again, sirs, and thank you to all the audience for joining us today for this webinar. And we are looking forward to the feedback coming in from you all. Thank you so much.
Thank you. Good night. Have a great weekend, everyone.
Good night.
Yeah.
Good night. Thank you.
Dr. Amit,
Good
we'll
night.
see you
Good
in
night.
best of.
Thank you.
Dr. Amit, best of ASCO Pune. You are
Yes.
invited. I think
Yes.
you've received the invitation. So
Yes, definitely.
please
Thank
do
you.
come. Yeah.
Thank you, definitely.
Thank you. Good night. Good night, everyone.